It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Thanks for joining me. Hope you guys had a chance to catch NYSIP, or the New York, New Jersey Pain Symposium, which is what we call it now. It's a great conference, and that was last weekend in New York. Coming up, we have a lot of good stuff. Today I have an IV ultrasound course in Manhattan. I'm doing those monthly on Wednesday nights. And if you're interested, this is really ideal for, nurses, PAs, anesthesiologists, ER docs, nurses, or anyone who really needs to place IVs and is not comfortable with the ultrasound and wants to get some practice with the phantoms and hear a short lecture about IV ultrasound. It's really a short course, and you get a certificate, CME credits. It's quite valuable for a lot of you out there. We do that in New York once a month on a Wednesday, and then my ultrasound courses are one Saturday a month, usually in New York, but I do go elsewhere, especially if there's a need, and it justifies the trip. So December 21st is my next ultrasound course in Manhattan, then January 11th is another one, and I'm going to be releasing more dates. I was just invited to present in Dubai, so if you happen to be at the Pain Expo in Dubai on April 26th and 27th with Sadiq Bayani, who sent me the invitation, please check it out. Would love to meet you there. I know a lot of you guys listen to this podcast, and because of the distance, we'll never meet. But this is my first time going so far east. So hopefully any of you who are in Asia or the Middle East or Africa or Europe who don't make it to New York or to America for the conferences we attend, if you happen to be in Dubai in April, I would love to meet up with you. And that being said, if you're not subscribed or getting emails from the Latin American Pain Society, I've been recently invited to the board, so check that out. The next conference is going to be in September in Chile, so I think you guys will really enjoy that. I've never been to Chile, and I'm kind of excited about that. So today's topic is an article written by Andres Rocha Romero, who I met at the IASP AMETD in Mexico City. And if you're on my YouTube or in social media accounts, you're seeing some videos of either me or Andres speaking and teaching. In one of them, he's translating for me. And we taught about the knee at this conference, and I have a lot more clips that I'm going to release. So if you're not on my social media accounts, just type in Pain Exam or my name, David Rosenblum, on any of your social media platforms, and you should see some of these videos. They're also on my YouTube channel. Also, Tony Ng wrote this article with King Hay Stanley Lamb, and the article is entitled Optimizing Genicular Nerve Chemical Ablation. And it's not surprising. This was published in the Korean Journal of Pain. It's not surprising that this is an article published by non-Americans. Why? We Americans tend to think we're the center of the world, and that everybody does things the way we do it. And outside of the States, and I've learned this from my work in Mexico and Canada and talking to clinicians elsewhere, people are doing more and more phenol ablations than radiofrequency ablations of the nerve. And that's possibly because of either payment issues or a lack of equipment, or the fact that phenol is fairly safe when used properly and has been around for a long time, and it's easily accessible. So they wrote a really great article, and this article, Andres actually was talking about a lot of these points in Mexico City and on these videos. So if you don't speak Spanish, I'm going to go over this article. It's in English, which is great. So they are talking about the optimization of phenol injection of the genicular nerves. And they're talking about there's a great picture of the anatomy for the medial branch of the nerve to vastus intermedius, which I have to say is a nerve that many of us in the States kind of ignore. Most of us in the States stick to the three main genicular nerves. Part of it has to do with either our training or the payment climate, which you're paid for three genicular nerves, and if you do something extra, you're probably not going to get paid for it. I'm not saying that's right or wrong. I'm just saying that's the way it is. And so many of us don't even bother with the medial branch of the nerve to the vastus intermedius. But there's a beautiful picture of it on the article, and I'm going to have the link in the show notes. I definitely think you should check this out. So they recommend a biplane use of the ultrasound to confirm the placement. And they have a couple of ultrasound images to show this. And it looks like they're getting the medial branch of the nerve to the vastus intermedius right above the femoral shaft. And you can look at the picture and see what I'm talking about. They also have another image of the superior genicular nerve and the medial branch. And they look at the adductor tubercle in the image, showing the needle insertion proximal to the adductor tubercle, and how you can reduce the risk of adductor tendon irritation when you inject the phenol. There's also a image of the lateral branch of the nerve to vastus intermedius and how they're positioning the ultrasound once again along the femoral shaft to get optimized placement. They also have the superior lateral genicular nerve and the anterior branch of the common peroneal nerve, and they show the probe positions on the lateral leg. And really, a lot of these injections that they're demonstrating here, I'm noticing are it's, I guess, fairly distal, and you're on the cortex of the bone. I don't see any images with the Doppler for the artery, but they mentioned that the landmark is the lateral femoral epicondyle, and they show the final positions. They have the recurrent fibular nerve, which is something also that is not routinely performed in the States. At least I'm not routinely performing it, not intentionally at least. And they're they're showing how to get this nerve as well as the inferior medial genicular nerve, which most of us do. And by the way, I have a little trick for finding this one. If you can't find it in the transverse plane, just go parallel to the shaft of the tibia, and you'll see it under the pes anserine where the kind of divot is. You should find the artery there, and that's a good landmark for this nerve. So they mentioned that determining the number of targets for the knee, because there's really many nerves that innervate the knee, is a new frontier because of many of us really only target 3, and they're saying that that's outdated. So I hope CMS is listening to that. Anyway, Ferrero has proposed a 6-target denervation approach for the anterior capsule, and Eng has proposed a posterior target for the posterior knee capsule involvement. Which targets are the most appropriate to establish a standardized procedure? Well, they recommend expanding the approach based on the patient's pain, considering 6 nerves instead of 3 nerves, by dividing the anterior joint space into superior medial, superior lateral, inferior medial, inferior lateral quadrants. The nerves that they recommend to be noted for blockade include the medial branch of the nerve to the vastus intermedius, the superior medial genicular nerve, the lateral branch of the nerve to the vastus intermedius, the superior lateral genicular nerve, the anterior branch of the common peroneal nerve, the inferomedial genicular nerve, and the recurrent fibular nerve. Although there is theoretical concern, extensive denervation may lead to a Charcot joint, but they're really not that concerned. They think that compared to chronic generalized neuropathies, these are controlled lesions. But their recommendation is to thoroughly examine the patient, to map the pain, and look for specific locations to denervate within the tricompartmental knee joint without causing excessive lesions. Based on the anatomical considerations, we recommend targeting the recurrent fibular nerve over the lateral condyle of the tibia, specifically medial to the superior tibiofibular joint. This location offers a distinct and optimal target for innervation, minimizing the risk of inadvertent injury to nearby structures. At this level, the common peroneal nerve is positioned on the lateral aspect of the fibular head, providing a natural anatomical barrier against extravasation of chemical agent towards the recurrent fibular nerve. Additionally, the anterior superior tibiofibular ligaments, the upper middle bundle, the fibularis longus muscle, and the extensor digitorum muscle further safeguard against inadvertent exposure to the common peroneal nerve. A study conducted by Ferrero corroborates the safety and efficacy of the lesioning at the specific RFN target, and it provides valuable evidence supporting the rationale behind the recommendation. They do not recommend routinely applying neurolytic agents to the infrapatellar branch of the saphenous nerve because its terminal branch is very superficial, increasing the risk of skin necrosis through either RFA or chemical neurolysis. While it's possible to target the nerve more proximally along its course, to minimize the risk of skin irritation, there is still the risk of allodynia of the skin and the dermatomal innervation. It's also a highly variable course for this nerve. Studies have shown that the branch does not frequently emit an articular branch, but it consistently maintains association with skin innervation. Therefore, it's recommended to engage in a thorough discussion with the patients before denervating this nerve, especially in cases of persistent concordant residual pain following denervation of either targets. Another critical issue they mention in the article is the size of the lesion. Regarding phenol and alcohol, it depends on the volume used for every target and the fascial plane in which it's deposited. Here in the study, they recommend 2 mLs, but previous research has achieved favorable outcomes with 1 to 1.5 mLs. Considering the difference in surrounding structures, the optimal volume for different targets should also vary. Many studies indicate anatomical variations in the course of the genicular nerve, thus suggesting more extensive lesions could be the best option. Nevertheless, they mentioned the key mechanical difference between conventional and cooled RF is the cooling effect and the large diameter of the cannula, which aids in enlarging the lesion side. The challenge when comparing radiofrequency lesions to chemical denervation is the shape and size is not as precise as those created by the electrical field. The larger the lesion, the greater risk of complications, and this applies to chemical lesions, but also RFA. The factors that affect heat lesion size have been described in detail, but not really so much with phenol. Therefore, the recommendation is to use minimal volume for diagnostic block and then apply the same volume for neurolytic procedures. They do acknowledge the advantages of chemical neurolysis. Compared to cooled RFA, it's cheaper, it's more accessible, and the distribution of the agent allows capture of most of the nerve fibers. Besides the continuous evolution of technology in terms of high-definition images, the constant rediscovery of precise anatomical targets are contributing to the performance of more accurate lesions. Another issue concerning neurolytics is the safety evaluation. When using neurolytic agents, secondary outcomes such as complications as important as the primary outcome related to pain control. Complications are divided into 2 phases, early and late. Typically, early complications are well known and described in most case reports, such as local pain swelling. However, late complications can also be described, and there may be incidences. There may be abortive regeneration, inappropriate redirection, and hyperinnervation events. Paresthesias were reported in the paper that they evaluated, but the duration and pattern of the paresthesia were not. It's possible that relatively high volume of injectate to certain targets contribute to this paresthesia. We don't know. They kind of question that. Finally, repeat procedures. They question how often should be repeated because they also worry about the biotensegrity of the fascia and the fascia integrity. Graded rehabilitation exercises that need to be carried out and strengthen the stabilizing knee muscles involved in the ambulation are a important factor here. And they're potentially reducing the load stress to the knee while increasing the protection of the knee joint through stabilizing muscles with those exercises. It may also prolong treatment effect and denervation when you do that. However, only a few studies have long-term follow-up, and they propose future studies. I got to tell you, Tony, Andres, and I have yet to meet Dr. Lamb, but this is a great article, and Andres sent me this article back in August when we did that talk together. I didn't look at it that closely as I did today, but this is making me rethink my genicular nerves. Because many of us in the States have this cookie cutter approach where we're just looking at the 3 nerves. I've expanded my repertoire to include the superficial genicular nerves, so the infrapatellisaphenous nerve I'm blocking, as well as the anterior femoral cutaneous nerves. And these are nerves that I'll block when the the deep geniculars fail, or I really don't have many other options. But if you're listening to the podcast, you've heard this already, but I'll just say it again. When you're seeing a patient who's had their knee replaced, and you do your geniculars and they don't work, and then you do your superficial geniculars and they don't work, and you do maybe your epidural because they also have an L3 stenotic foramen and it doesn't work, and you may even do a PNS device and it doesn't work. Well, before all that, examine the patient, look for allodynia, and yes, even in the 80-year-old, they can get complex regional pain syndrome. I've been burned by that. I've missed that and delayed care because I failed to acknowledge that this could just be a CRPS situation, and then you finally do the lumbar sympathetic block and the patient responds. So elderly patients who get their knee replaced are not immune to complex regional pain syndrome. We tend to think of them as the 20, 30-year-old females who get it, but it could happen to almost anyone. So just keep that in mind. So yes, great study, or paper, I should say. And I look forward to hearing more from these docs. I mean, this is a very useful paper, and it may change my practice. Unfortunately, the way we're compensated in the States has led to many of us to just do our 3 deep geniculars and not really think so deeply about these other nerves, but hopefully that will change. Once again, I hope to see you guys at my upcoming ultrasound courses in New York, or perhaps at one of the conferences in Aspen, in Miami, or the Pain Expo in Dubai or Chile for the Latin American Pain Society. Thanks for listening. Please share the podcast. Please review the podcast. And if you're not already on the nrappain.org news list, sign up, subscribe. I send out updates as well as some free info that might be useful to you in your practice. Thanks again.
It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.